Hello, today I am going to be doing my grand rounds presentation on an anterior talofibular and calcaneal ligament sprain. I work for AT Direct Sports Medicine, but my clinical is Chandler Preparatory Academy. It is a small 2A public charter school. Even though our enrollment is small, almost 70% of our school plays at least one sport. I am only contracted for part-time and usually work 4 days a week. I am the only athletic trainer, and I am responsible for providing services for all high school and middle school athletes. I'm present at all high school home games, but I only travel for football games. My policies and supervising physician allows me to make all immediate decisions, and athletes are not allowed to return to play until I clear them. My coaching staff, administration, and myself are big advocates of prevention, and most rehabs, including post-surgical cases, are done by myself. Because of this, most of my time is either spent doing rehabilitation or game coverage. This particular patient is 18 years old, male, and a multi-sport athlete. However, basketball is what he considers his main sport. He has a history of chronic foot and ankle injuries and sustained a minor ankle sprain and foot contusion earlier in the fall during the football season. He is a 4-year varsity athlete, team captain, and rarely leaves the game, especially on his own terms. It is also important to note that he is of Egyptian descent. I have several Egyptian families at my school, and the male children are usually very independent at this point and make their own decisions as if they were an adult. Also, females are seen as more of caregiver roles and not so much as healthcare providers. However, my medical advice has never been disregarded by families of this descent. It is just something that I need to note, and oftentimes will bring the supervising physician in, who is a male, to help further my point if needed. I also rarely speak to parents directly, especially the male authority figures of the house. The athlete primarily lives with his dad, so most communication occurred between the athlete and myself, and I assisted the athlete in relaying communication onto his dad to make sure that everything got communicated accordingly and properly. Both of my basketball teams were away at Antelope Union High School, which is about 2.5 hours away from Chandler Prep. There is no athletic trainer at that school, and it's important to note that they do not usually have a QMP or a qualified medical professional at any sporting event except for football, and even then, it's usually pretty questionable. During this time, I was at Chandler Prep covering soccer games. I got a call and numerous texts from parents and my girls' basketball coaching staff saying that this particular athlete went up for a rebound, landed, and stayed down, but was able to limp off the court. They also communicated with me that the athlete had removed himself from the game and was sitting on the bench with an ice bag. I spoke with the athlete over the phone, where he told me that he was not wearing his ankle braces and that he felt a massive pop when he landed, but the pain was nothing too crazy at the moment. It's important to note that this happened on Friday night, and I was not scheduled to work until the following Tuesday. That night, the athlete sent me these pictures. I explained to him that swelling was a normal occurrence and instructed him to avoid any kind of anti-inflammatories. However, he could elevate and ice for pain purposes. Because of the nature of the situation and the timeline that we had to deal with, which I will go into further later on in this presentation, I came in on Saturday morning during film to assess the athlete. The athlete had restricted range of motion in plantar flexion, dorsiflexion, inversion, and eversion. 2 of the 3 Ottawa ankle and foot rules specific to the ankle were positive: the inability to fully bear weight and pain over the lateral malleolus. These rules are excellent at ruling out fractures. The talar tilt and anterior drawer tests were positive for pain and laxity. However, due to the athlete having chronic ankle laxity and instability, the validity and reliability of these tests may be in question. So at this point, my differentials were 50% a fracture, 40% an anterior talofibular ligament sprain, and then 10% a calcaneal ligament sprain. Because of my initial exam findings, I did send the athlete for an x-ray that following Monday. Upon parent request, an MRI was also ordered. X-rays did come back negative for a fracture, and the MRI eventually came back as normal, with the exception of thickening from previous trauma to the ATFL. So before I get into the patient care plan, it's important for you to understand the timeline that we were on and why certain clinical decisions were made. The initial injury happened on January 31st, and I did the initial eval on February 1st. That following Monday, on the 3rd, he did get x-rays. This was at the end of the season, and my team was very much so set to play in the state tournament. And with him being a team captain and a pretty influential player of the team, this one was a little bit challenging. This is where we aim to have the athlete return to play. I would also like to disclose that no promises of returning to play on that date were made. It was simply a goal made by the healthcare team to shoot for. It is also important to note that while I was the primary healthcare provider on this case and made most of the care decisions, my team physician did approve all progressions and made the final decision on whether the athlete would be returned to play. This was done for a number of reasons. One, I wanted to make sure that the athlete's safety was still at the utmost importance, but also to have another set of eyes to also approve and to make Dad feel a little bit better about returning. The first plan of care focused on protecting the injured tissue. I chose to put the athlete in a boot instead of on crutches so that he could remain weight-bearing. Localized compression was used at night to help control swelling after the first 48 hours. The primary interventions used during this time were tarsal mobilizations, toe movement exercises, and manual therapy techniques to help control the swelling. Ankle movement was minimized during this time to help protect the suspected injured tissues. Since we knew that if the athlete was going to return to play, it would not be under ideal circumstances, an effort to keep the athlete's cardiovascular health was up at the utmost importance. For the second plan of care, the athlete started transitioning out of the boot except during school days when he would be walking in crowded hallways and a very uncontrolled environment. During this phase, we worked on improving ankle range of motion and started balance training immediately. The athlete's gait was assessed each day to ensure that the walking boot was not changing the way he walked and that he would eventually be able to run and transition to sprinting seamlessly as his sport would require him to do so. During the third plan of care, this would take up the remainder of treatment. Interventions during this phase were changed daily to meet the athlete's needs. Because of the timeline we were on, the athlete was advanced quickly, but never passed pain levels that the athlete rated as a 3. We also knew that the athlete would likely not be at 100% come game time, but we made the goal of getting the athlete to 85% or higher. Most of the time in this phase was working on sport-specific movements in real-time situations. During this time, the athlete was also doing modified practices with the team that allowed him to ease back into sport in a controlled manner. The athlete continued coming into rehab after the game until he was at 100% because communication was had that he would not be at 100% come that 19th. The patient-reported outcome measures that I chose to use were the PEDS-QL and the FAM. I chose the PEDS-QL because it is a generic measure that's validated for pediatrics, even though this athlete was 18. The PEDS-QL is what I'm a little bit more familiar with at my setting. It is 23 items with a physical health summary of 8 items, as well as the psychosocial summary of 15. Higher scores mean better health-related quality of life. And then with the FAM, this is region-specific, 21 items. It does have a sports summary, which was incredibly helpful, and higher scores also mean better health-related quality of life. The FAM has also been proven to be highly reliable and valid. So here's just a little bit of a timeline. This is just a little bit of a graph to help show the improvement over the time period we were working with. Note that this is where we began phase 3 of rehab approximately 10 days after injury. Because of these findings, that day and the next several exercises were modified to be intense, but also to not worsen the athlete's progress. Patient communication was essential during this time. Also, this is theoretically where the athlete was when he was allowed to return to play. I don't believe this graph accurately represents the athlete's status at the time. While the athlete was not 100%, I do not believe that his scores would be this low. I think his scores were definitely closer to those that were taken on this February 25th. I collaborated with my directing physician and communicated with him throughout the entire weekend and really throughout the entire case. He was instrumental in being sure that the athlete got the care that he needed as quickly as he possibly could. He also was very helpful and supportive in my clinical decisions and in allowing this athlete to return to play, even if he wasn't at 100%, because he was a senior and this would be the last time that he was going to get to play. So some of my lessons learned were that over the last 2 years, everything kind of came together of what I've learned from my master's. I used to be a very aggressive athletic trainer, particularly with ankles. So the more they could move it, the faster they could move it. And the quicker after injury, the better I thought they would be off. This time I decided to take in tissue healing into the matter and tissue timelines, and it really was a game changer. So understanding physiologic tissue healing and timelines absolutely matter. Pros also don't tell the whole story. While they absolutely are a piece of the puzzle, they shouldn't be used as your sole clinical decision maker. And that also that patient-centered care is complex and very different for each person. I have several different athletes that could have had the same exact injury at the same exact time, and it wouldn't have gone this way because they're not the same people. But leveraging relationships was also huge in helping this athlete succeed. My physician was instrumental in being sure that he got the care and the imaging that he needed quickly. The athlete was very willing to trust me and work with me and do everything that I asked of him, and he was even able to trust me during the not so easy days that he didn't understand because I did know him very well. Same with the coaching staff. I have a great relationship with that particular coaching staff, and they were very not pressuring at all to get him back, but were very willing to work with me in the event of getting him back on the court and getting him back safely. And then his teammates really helped in the psychological side of the injury. The athlete was a senior, had a very difficult time knowing that his season was potentially cut about a month early and that he wasn't going to really play basketball again in his life in this way. And his teammates really helped encourage him. Were there, a couple of them did his circuit trainings with him, things like that. If I could change anything about this case, I think that it would just be to do a patient-reported outcome measure probably before I returned him to play for game time. However, I don't think it would have changed the clinical decision that I made. It just would have given me a little bit more evidence. Overall, I don't think I would change really anything about this case. It went very well. I changed my approach prior to. It really kind of highlighted and showed my growth over the last 2 years. And I think that's why this ordinary case was really so cool and surreal for me.